Late.
Hey, how you going? Can everyone, am I live?
Yes,
Can
you
you hear
on.
me?
Yes, you on. Go ahead.
Thank you, and it's a pleasure to be presenting to you all there in Thessaloniki, and it's disappointing that I can't be there in person to present this short paper. By way of disclosures, I do recognise the support Medtronic has provided me over the last year and a bit to really get to understand MiECC. I do need to say that I am a bit of a guideline junkie, and we don't currently practice MiECC at my institution. So by way of an outline for this brief presentation, why is it important to get MiECC into the guidelines? Where does MiECC currently sit? What's the new evidence? And what should we expect in some new recommendations? So why is it important to get MiECC into guidelines? This quote, I think, from the Institute of Medicine back in 1992 really says it all. These are systematically developed statements that are to assist us as practitioners and also our patients about some really important healthcare decisions. And I think the second quote also highlights the importance of clinical practice guidelines, as they really can make a difference in improving both the quality and the process of care for our patients. Where does MiECC currently sit? Well, this is a picture of a typical landscape drive in Australia, and often the kids would say, are we there yet? Well, I think in terms of where MiECC sits, we're not quite there yet. If you look back to the 2011 update to the STS blood conservation guidelines, they had a number of recommendations that related to components, if you will, of what MiECC has become. Reduced priming volume was a level, class 1 level A, the use of vacuum-assisted venous drainage, biocompatible circuits, and retrograde autologous priming were all components that were recognised as being very important. In the 2017 EACT blood management guidelines, there was similar recognition of the importance of this sort of technology in improving and reducing the amount of bleeding and also the amount of transfusion that occurred in our operative situations. And the EACT guidelines actually went further and made a recommendation in respect to MiECC systems in their entirety, and that they should be considered over standard conventional bypass systems to reduce perioperative bleeding, or transfusions, I should say, and they gave that a 2A level B recommendation. Earlier this year, the task force led by Luke Pui and Milan and other high-profile participants produced this set of guidelines on cardiopulmonary bypass in the adult patient. And they made a number of recommendations in relation to MiECC. And you can see that all of these recommendations were at the 2A level, suggesting that whilst there's a direction that's been clear, the level of evidence really doesn't fully support a stronger recommendation at this time. And everyone in this room would be familiar with the 2016 position paper, and this was a landmark paper in terms of development, I think, of minimally invasive extracorporeal circulatory technology. And in that paper, there were 10 recommendations made. 4 were given a class 1 level A level of evidence. So if we look at the evidence as it stacks now and immediately after that position paper was written, there were 2 meta-analyses, and just reminding ourselves why we should look at meta-analyses. They give us the opportunity to put all these smaller studies together to give us a bigger study population. We have to ask each time, is it a clinically sensible meta-analysis? Is it a meaningful meta-analysis? And will it impact our practice? But these 2 meta-analyses that looked at MiECC, firstly, this one from Sunul from China, looked at 41 randomized controlled trials and was well designed. And the second one from this group of Kowalski and authors, both of them demonstrated good technique in developing a meta-analysis. And really, I think collectively, they gave us a lot of supporting evidence for the position statement that had been published in 2016. So if the evidence is so good, why hasn't everyone adopted MiECT? And I think to answer that question, we've really got to look at what the studies actually compared. Is there any new evidence, and how does that help us? So what's new? Well, I'm just going to briefly skip through. There are about 6 papers, 6 randomised controlled trials that have been published since then. The first by Kyriakis and his group here in Thessaloniki, and this is a small randomised trial, really looking at the quality of life as an endpoint at 30 days and 3 months. The second was a slightly larger study from Germany, looking at 200 patients, looking at post-operative inflammatory and inflammatory markers. The third was a trial of 120 patients, once again looking at kidney function. Another one from Kyriakis' group, looking at the learning curve, if you will, of the introduction of minimally invasive techniques, and then a small study looking at various biomarkers of the inflammatory response. And finally, a second small randomised study looking at biomarkers of inflammatory response. And what was significant in all of these studies, and they added some 614 new patients, but they showed that MiECT was better in terms of the outcome measures that they reported. However, there are still issues with the literature. Are we comparing apples and oranges, or are we actually comparing apples and apples? There's still a lot of coated versus uncoated circuitry in the literature. There are small versus large volumes primes, when a lot of the world has moved to a much smaller volume prime. Then there's issues of use of centrifugal and roller pumps, and the use or lack of use of soil salvage. But if we move forward, I think in the short term, we need to focus on the quality of the work that's being done and focus on the elements that make up MiECT, and develop the understanding of what's seminal to the adoption of these techniques, and that is understanding how teams work. In the midterm, we can look forward to the COMEX trial bringing us some new science. Finally, in the long term, we're all working towards the same thing, to get the best outcomes for our patients. So if MiECT really works, then MiECT centres hold the key. And to unlock that power, they need to develop a strong, robust registry to support the myriad of small randomised controlled studies that are published, and the COMEX trial. We have to remember that, as Paul Batalden said, every system is perfectly designed to get the results that it gets. So if we don't pull together and provide good literature, good science as the input, then the system, that is the cardiac surgery community, won't be able to come up and adopt these sort of techniques. That's how well we put it in is going to determine how well the technology is adopted. So we know there are issues. We know that there's still work to be done. But thank you very much for the time.
Gianni, may I ask a question to Rob?
Yeah, please do.
Rob, it's Kyriakos.
Yep.
From what you've told us, from the position paper, it seems that 6 studies included 600 more patients to the cohort of the randomized patients from the trial so far. That counts roughly 3,500. So it is exactly the number that we are aiming for with the COMEX trial. So should I go with an assumption that this is, let's say, something that gives us an indication of the result, or it is too much to say that level of evidence B from these trials is not enough sample? Taking under account, though, before you answer, that none of the trials that have been so far involved in this comparison, none, 0, not even 1, indicates that MiECT is inferior to conventional. All of them are having superiority. So is this, repetition something like a signal for the COMEX trial?
Look, I think that's why the wider community is continuing to watch this space, and why the MiECT movement is growing. All of those trials are showing us the same direction. And, we only have to think back, and you can, the chap sitting next to you, John Murkin, can answer this, but in a lot of the advances that we've looked at over the last 20 or 30 years, it's been totally rare to see every result going in the same direction. And that's where this technology, this combination of technologies that we've tried to adopt through single direction studies. If we look back at the studies looking at biocompatible surfaces, if we look back at, INVOS study, sort of cerebral oximetry studies, all of these areas were blighted by the fact that we had small trials and often conflicting results. Whereas looking at the MiECT studies, they do all show the same direction, and that's quite unusual. But we're certainly not at the time point where we can move on from a 2A level evidence. We don't have the big trial, and we don't have good registry data to support that. So we're sort of, I think we've moved a long way, but I think, we definitely have a ways to go.
We have a question for you, Rob, from the panel here.
So I'm not a clinician. I'm a physiologist.
It's Jan Inns from Amsterdam. Yeah.
And I operate in intensive care medicine. That's my area. And when I hear a hopeful therapy like the MiECC and conclusions being we need bigger trials with more numbers, I look at practically every large number trial in intensive care medicine today has shown no difference. Whereas we know with n is equal to 1, which is the only significant statistics for a physiologist, that there certainly is a big difference. And what's missing, and is the elephant in the room, is that we don't know exactly what we're doing. So the hope is that if we've got large enough numbers, that there is somewhere a p-value showing some sort of significance for some arbitrary outcome without really first sitting down and looking very, very specifically at what phenotype is being influenced by using therapies like this. So I would like to make an appeal to don't put all your hope in large numbers, because especially from Australia, we've had a lot of very, very large trials coming out of there with a lot of patients being included who have really shown no effect. And what people then think is, well, absence of evidence is not evidence of absence. And that is something I think that we really need to think about, because this certainly is a promising technique, a very promising technique. And if you put all of your bucks on the large trial with thousands and thousands of patients and see no difference.
Well, that means there is no difference.
No, it does not. That's exactly what I mean. Absence of evidence is not evidence of absence. It's John Locke, 1632. Just because you've not been able to show a difference doesn't mean there is no difference. It's a different trial.
Yeah,
But that's exactly what the
we are
cardiologists
living in
do.
a world of
Non-inferiority trial is a well-accepted evidence base now for any cardiology trial. So anecdotal cases don't have any statistical relevance, but non-inferiority, forget superiority, because that, I agree, in major trials you don't see that. In off-pump, on-pump, that's what it failed for. But
Well,
the cardiologists get through by just simply saying non-inferiority.
So the reason, in my opinion, again, I'm, not a clinician at all. So this is a voice from outside, sometimes wakes people up. And the reason for off-pump, on-pump, as an example, is because people don't know what's going on. Now, we looked at that particular, and I can tell you exactly why there was no difference, is because you get hypoxemia due to iatrogenic heme dilution in on-pump, and due to luxation, you get obstructive hypoxia in the other. So in both conditions, you're inducing hypoxia. So it doesn't surprise me at all if you don't find a difference in outcome. So, but if you use an aspirin trial, for example, very simple. You know what the pathophysiology is. There's a clot somewhere, and you've got a drug in which it's exactly known what it does. Then it makes sense to do a large randomized control study. But now we're talking about uncertain medicine. And there, I think you're going into risky territory. It's all I want to say.
Can I have a retort to that? Just a quick one. Whilst you quite rightly pointed out the physiological importance, but the main drawback for the off-pump, on-pump was the number of grafts, the inadequate, incomplete revascularization, the repeat MACE, the repeat revascularization. So there are some practical aspects that you have to look into apart from the physiology, for which there may not be much basis, which I fully agree. This is what most of the things we do not know exactly in depth at cellular level, what is the importance and changes. Absolutely. But I think when it comes to the minimal invasive and the standard CPV, what we really need to hone down is the basic physiology at that level, because that's the strength there. There is no strength of the number of grafts or anything. But rather than adopt a positive attitude, for which I think you may need 10,000 patients to see a difference, you just adopt a non-inferiority one, which is how the cardiologists get through every day. And they push it in your face. Look at TAVI, without question, simply a non-inferior thing, nothing to do with better. That's all.
He has a
Yeah, this is Young Choi, also from Germany. I just would like to comment on the non-inferiority trials and the superiority. When you are the gatekeeper, you can just bring up the non-superiority or the non-inferiority trial just to justify what you're doing, but it doesn't show that you're better. So we should not, the surgeons who are here are not the gatekeepers for cardiac surgery. So we cannot come up with a non-inferiority trial. We have to come with superiority. What we're really missing is a trial that focuses on hard endpoints. It's the same with cardioplegia. We can operate the patients with any kind of cardioplegia, and at the end we will show there might be some benefits in terms of morbidity, short-term outcome, but on the hard outcomes, on mortality, there's no difference. So this
Now,
seems to be...
Sorry, this is getting very confusing, and we will be here all day discussing this. If you want to do a trial on mortality between, I don't know, on pump or off pump or whatever, you need 50,000 patients. Nobody's ever going to do that study. Now, with comics, which of course I'm advocating because I design it, we are going to have 12 hard points: mortality, stroke, renal failure, bleeding and requiring reoperation. Now, I'm not suggesting there will be a difference. In fact, I'm completely neutral to this. But whatever it comes out, it's got the power to tell you, is it better, is the same, or is worse? I don't think there's any question about that.
I think there is a question from from the online participants. That is, which are the main training programs in MiECC? I don't know if someone can answer this. Maybe, Ashraf?
I don't understand anything about studies.
I'm sorry, I don't know a single training program for MiECT for surgeons. For perfusionists, I don't know the answer, but I'd say there isn't any. And please correct me if I'm wrong.
Well, there are companies that are having thorough trainings, multidisciplinary, as I know for Medtronic, for example. But this is not, let's say, from societies or for disciplines. I don't know if Cyril knows from perfusion standpoint.
Well, I know of, I mean, when I brought my team to train, we brought them to Bern, and we did 3-day training in Bern, Switzerland. And I think there's Medtronic has a few specific training sites. Aren't you guys a training site for perfusion in Braunschweig?
Yeah, I totally agree, but this is, for me, this is not a program. A program is something like Adrian said for TAVIs. You go, you see how it works, you get a proctor, a mentor. From my perspective, mentor would be a whole team, a perfusionist, an anesthesiologist, and a surgeon who come into your center and stay there for a week and help you do different cases and show you how it works. I don't know a single program that does that, and I don't know a single company that does that.
It is Medtronic that starts now. And so far we had some trainings with simulation and multidisciplinary trainings for Medtronic, but now we started this schedule with 3 stages. First, the hands-on simulation training, then proctorship, and first 50 cases cabbage, and then advanced training with Modular MiECC. So this is how it's going to be. But again, it's not from society.
But I definitely believe
Sponsored.
that this is the only way to go, and this is the only thing that I would call a training program.
Sorry to interrupt you because we're running out of time. In fact, the next presentation from Professor Wahba is supposed to actually discuss exactly this. Please.
Is Alex with us because he requested to be at the end just because he had a problem with connection? I don't know if, is Alexander online now? No,
No.
he requested to be the last speaker because he had some problems.
Okay, in that case, why don't we ask